ferritin was elevated. She had features of multi-organ dysfunction. Shock, which was very difficult to manage, a fluid refractory, inotrope-resistant shock, and extra chest was showing bronchopneumonia. And being a COVID season, we did this nasopharyngeal swab, which turned out to be positive. It was treated with antibiotics, antivirals, and other supportive measures. Shock was difficult to treat, correct. She had one more cardiac arrest. And then, unfortunately, the child expired on the 4th day of admission. Just wanted to share with you our experience. That was a bad experience, really, in fact, because most of our cases were easy to treat, mild symptoms, but then this one had severe symptoms. But of course, this child had several underlying comorbid conditions, and we could not save this child. As we all know, this virus was first reported from China in December 2019, and after that it spread to almost every country in the world. And actually, that has actually changed the way we live today. Our life has changed now after this COVID virus came with full force and has affected all our lives now. And as you can see here, this I took in the morning actually. And that data is from yesterday's statistics, and you can see that India is third country having the maximum number of cases now. And the last column actually is for new deaths. New deaths, you can see that the maximum number of deaths happening in India now. Day before yesterday, it was 664 deaths in one single day. And as you can see in the morning today, 22nd July, it's more than 1.5 crores cases now all over the world, with more than 6 lakhs deaths so far recorded, and the number is increasing. So it's not a very, very rosy picture that we see as far as COVID-19 spread is concerned. I know that it's a highly infectious virus, and we all know that the main route of transmission is respiratory droplets. And most of the cases, majority of cases, spread is through respiratory secretions and saliva. Aerosols are also there. It's a cause for concern for all of us who work in closed spaces like ICUs, because aerosols, as you know, once generated, will be there in the atmosphere for some time, unless you have a mechanism to get rid of those aerosols by some negative pressure or something, which is not available in most of our hospitals. And spread through fomites is not a very good way of spread. It is possible that this can spread through fomites, but not very much. And possibly, some people have suggested fecal oral transmission also, but then it's not very common. And so far, mother to fetus, sorry for the spelling, transmission has not been reported, direct vertical spread, and this virus has not been detected in breast milk so far. So that's the situation. And unlike adults, we have, fortunately, the severity is less in children, unless they have a comorbid state like what happened in the first case. And many of the respiratory viruses, as you know, have a very severe course in children. Like, for example, we had a very, very bad outbreak of adenovirus infection in our ICU, in many other ICUs also in North Kerala, some 5-6 months back, just before this COVID spreading. So we had this adenovirus outbreak, and adults were practically spared at that time. Most of the severe cases were occurring in children, young children especially, and we had many, many deaths also. But unlike that, COVID fortunately affects adults more than children. And this is a large study published from China, published in Pediatrics Journal 2 months back. More than 2,000 children, 2,143 children, and only 6% of children required intensive care. But then, as you can see there, infants are more affected. 10.6% of infants required intensive care, and only one child died, 14-year-old child died. So that fortunately is very uncommon in COVID infection. And children, most of them have asymptomatic or mild illness, and severe or critical illness is more common in very young children, infants and toddlers. Infants, especially those babies who are less than 3 months of age, have a potentially have a serious illness. But we, as such, do not have that much experience here. Based on experience from community-acquired pneumonia, I'm not talking about COVID alone. The children having underlying illnesses are likely to have a more severe disease. Obviously, congenital heart disease, like what happened in our child. children having bronchopulmonary dysplasia, or already existing airway or lung anomalies, congenital anomalies, malnourished children, primary or acquired immunocompromised state, immunodeficiency, primary immunodeficiency or acquired immunodeficiency, obesity and diabetes, just like what is there observed in adults, children having obesity are also supposed to be having higher risk for development of severe illness. And type 1 diabetes is there nowadays more common, and it's likely that some studies in US, they have shown that children with diabetes have a predisposition to have a more severe illness. This was published in New England Journal of Medicine recently in April. About 171 children. 50%, almost 50% of them had respiratory symptoms like cough, sore throat in about 46%, fever 42%. But then you can see that diarrhea and vomiting, about 9%. Diarrhea and vomiting, 6% of children. Nasal discharge, 8%. And fast breathing, 30%. And in cases where they did CT scan, 63% had abnormalities. What we have seen in our hospital in the present outbreak, we have some cases, about 50% of them have mild respiratory symptoms, and about 10-15% of them have GI, gastrointestinal symptoms like diarrhea and vomiting. Remaining 50% remain asymptomatic. As per government policy now, we are admitting all cases of positive, RT-PCR positive means we admit them. So we know that we have the data now. Children, not many children are there, but then out of about 15-20 children, we so far had 50% of them had symptoms. Out of that, 50% having respiratory symptoms, and about 10-15% have gastrointestinal symptoms. Why I tell this is that it's important that you need to consider COVID-19 in children presenting with gastrointestinal symptoms also, like diarrhea and vomiting. So that could be the only manifestation sometimes. So in the right epidemiological circumstance, like if there is a contact or anything, and a child presents with diarrhea, think of this also as a possibility. And another not very common presentation is this, that is a multi-system inflammatory syndrome in children, which has been recently described in April in UK. They noticed that a clustering of cases which look like Kawasaki disease classically. You heard of, you know what Kawasaki disease is. It presents with features of inflammation in a child who is having fever. Febrile child having conjunctivitis, some kind of rash, some red mouth, inflamed tongue, then peripheral edema, then some desquamation and all that. So this type of rash is very, very common, a Kawasaki-like presentation. But then if there is a clustering of Kawasaki disease, you need to consider the possibility of some other inciting agent, and they thought of this, and then they found that many of these children who presented with Kawasaki-like syndrome or disease had evidence of infection with COVID-19. So, and then I think they have started observing that in other countries also. There are many reports from India also now. Recently, we had one child presenting with features of severe abdominal pain, vomiting. Child was diagnosed to have upper abdominal pain, and child was diagnosed to have possible acute pancreatitis, and they did a CT abdomen, and CT scan was showing features of acute pancreatitis. And lab investigations are also suggestive of acute pancreatitis, like increased elevated levels of pancreatic enzymes, lipase, amylase, and all that. But then this child was showing features of raised inflammatory markers also, with like very high CRP level and other features of inflammation, like high ferritin and other. So these are cases where you have to consider the possibility of this multi-system inflammatory syndrome related to COVID. And the most important thing is that this multi-system inflammatory syndrome in COVID in children will manifest only after 2 to 3 weeks after the actual infection with this COVID-19. So they may not be infectious at this stage, but then they have this hyperinflammatory reaction of the body, and that can be sometimes dangerous. They present with features, most of them present with abdominal pain. So abdominal pain is another symptom which you have to be careful about in these children with possible COVID-19 infection. So any child present with severe abdominal pain during this season also, you need to consider COVID-19 as a possibility, and this particular syndrome, multi-system inflammatory syndrome, and you need to look for markers of inflammation like ESR and CRP, and if they are very high, you think of this. There will be features of other system involvement, organ dysfunction in the form of hepatic dysfunction or myocardial dysfunction or acute kidney injury and other things. And you need to maybe treat these children in that line, possibly with intravenous immunoglobulin or methylprednisolone, that's corticosteroids. So they have certain criteria proposed by US researchers. A child having serious illness leading to hospitalization, a younger child, 21, less than 21 years. Because this, Kawasaki disease is more common in young children less than 5 years of age. But what they have seen in this particular syndrome is that most of these children are above 5 years of age, but then adolescents, less than 21 years. So that's the age group when they present with most of them, but young children also can have this. So in the criteria, they have mentioned the age less than 21 years, fever more than 38 degrees Celsius, or if the mother tells you that there is history of fever in the last 24 hours, she feels that there was fever, lab evidence of inflammation, as I told you already, and evidence of multi-organ involvement, like for example, a liver disease, liver dysfunction, or a myocardial dysfunction, or acute kidney injury features. And if there is a lab confirmation or an epidemiological link with COVID-19, you think of this possibility, because this is likely to be missed unless you think of this possibility. Child presenting with severe abdominal pain, some rash, and then you do an ESR or CRP, it is very much elevated. There are features of organ dysfunction. You need to think of this. But COVID-19 RT-PCR may be negative, because this usually happens after 2 to 3 weeks after the onset of infection. But you might get positive antibodies to COVID-19 if you have the facilities to do that. Unfortunately, that's not widely available now, COVID antibodies. But if that's available, you can do that. And this is a large series they published in New England Journal of Medicine again. 186 children with this syndrome in the US, where they have a lot of cases, recorded COVID-19 symptoms before the onset of these symptoms only in 14 children. So symptom suggestive of COVID-19 infection may not be there in many of the cases. Only 14 children out of 186, they had these symptoms before this. COVID-19 symptoms like fever, cough, and respiratory symptoms and all that. And the mean interval from COVID-19 symptom to multi-system inflammatory syndrome was 25 days. It takes more than 3 weeks. There is probably some history of fever, cough, or something, and then after 2-3 weeks, they'll present like this. So the median age was 8.3 years. Males slightly more than females, 62%, and at least 4 organs were involved in 71% of these cases. So that much about the presentation. Like they can present with like asymptomatic or any other respiratory illness, or sometimes rarely this multi-system inflammatory syndrome. So important point to remember is that any child presenting abdominal pain or GI symptoms also you need to think of this possibility. And what are the pointers of severe disease? Like if it's a young child, I think, 1 second. Meeting young infant, less than 3 months, you have to be very careful about. The child has breathing difficulty. That's obviously a point for severe disease. Persistent fever more than 3 to 5 days, again, altered sensorium, abnormal liver enzymes, abnormal cardiac enzymes, LDH. The child has unexplained metabolic disease. In a person who already you have diagnosed RT-PCR positive COVID-19, child has unexplained metabolic acidosis, means you need to think of possible complications, extra pulmonary complications. And if there is evidence of co-infection with other viruses or bacteria also, you have to be very, very careful. So I am supposed to talk about emergency in pediatric COVID-19. So we will talk about our concerns as far as how much we should be prepared in the ICU, administrative concerns also. We know that we have done all this in all of our hospitals. You identify an area where COVID patients are to be managed. We have an isolation ward here now. Separate ICUs for suspected and confirmed cases. This is a serious issue. Like most of the time, you do not know whether the child has COVID or not. But then if there is anything to suspect that, ideally, you need to have a place where you can keep these suspect cases. And once confirmed, you can transfer them to the confirmed isolation for area for COVID. And we already have started seeing a surge now. There is an increase in number. We need to have other plans also, like the plan B, plan C, and all that. In case the number increases, we need to find out more space for ICUs, more space for wards. where you admit COVID-19 cases. And if possible, we need to have negative pressure rooms if possible. We have some theaters and all now already, labor room and other places, negative pressure rooms are there. Why do we need to have negative pressure rooms? Because it has been found that this virus can spread through aerosols also. It's not just droplets. Aerosol spread is also possible. And you know, aerosol generating procedures are there, like you do an endotracheal intubation, you do a throat examination, or just the child has a sneeze, child starts crying suddenly, you do a nebulization. Of all these procedures are likely to create aerosols, which can remain. These are smaller size particles, so they can remain in the atmosphere for some time. So if you do a procedure like this and then somebody goes into that room, after some time also it can spread. That aerosol can cause infection in that person, and it generally takes about 20 minutes for these aerosols to settle down. So unless you have a negative pressure room, so it's better that you always have a negative pressure room ideally, or at least you have to have rooms where there is adequate air circulation taking place. So if you have a closed room like a split AC room where all the windows and everything is closed, means it's a very high risk for aerosol spread. So it's better that you have a room, preferably on the higher floor of the building, and make sure that you have all resuscitation equipment ready. We have that in our ICU. We have a practice of keeping a crash cart there with all the resuscitation drugs, equipment, everything ready. And it's very important that you maintain a trolley like that, resuscitation trolley with essential drugs, monitors, ventilators, everything ready. And it's better that we are prepared for this. Any emergency for that matter. Even before the onset of this COVID outbreak, we had all these preparations there in our pediatric ICU. So I think in the COVID ICU also need to have that. When you transfer the child to PICU, the child has an unstable cardiorespiratory status. The child has obviously severe respiratory distress. These are all indications even other ways for transferring a child from the emergency to the PICU. But then you need to have a definite standard operating procedure like written somewhere, like impending respiratory failure. Obviously, we would transfer the child to PICU, grunting, not able to feed, altered sensorium. The child has a saturation that is not maintained above 92% room air. So these are all features of respiratory distress or respiratory failure. So in a situation where these are all features of a severe acute respiratory infection. So any child having a SARI-like symptom in the setting of COVID means always it's SARI-like symptom during this season, suspect COVID and transfer the child to the suspect area, and transfer the child to the, do an RT-PCR, a confirmatory test, and then admit the child in the COVID ICU. Child has features of circulatory failure also. So cardiorespiratory instability is one indication to transfer the child to PICU. And treatment of SARI is severe acute respiratory infection. All of you know that. Or ARDS, like any other child having an ARDS, you treat in the ICU, like any other viral pneumonia. And the most important thing here, or maybe the most important difference that we have from other children having viral pneumonia is that you have to avoid spread to healthcare workers. Because once the healthcare workers are infected, means you know what will happen. And as we already discussed, protection from aerosol. So aerosol is a serious, aerosol-related spread is a serious issue as far as hospitals where these children are treated is concerned. And oxygen is indicated if the child has a saturation less than 19 room air, or 92 is the cutoff that we usually keep, of features of respiratory distress. And you might have heard of adults having, they call this happy hypoxemics. Like they don't have breathlessness as such as a symptom, but then if you do a pulse oximetry screening, you know that pulse value is less. So hypoxemia. So hypoxemia may present without distress in children with COVID-19. So it's a good idea to check pulse oximetry in all children or adults also with suspected COVID-19 infection. It's better that you use low flow devices, because high flow devices, again, there is a chance of generation of aerosols. So if with low flow device like a nasal cannula, 2 to 4 liters per minute is sufficient to maintain the saturation above 92, that is okay. And it's always better that you use a mask when you transfer the child to an area like a PICU or anything. Even if you're giving oxygen with a nasal cannula, but then put one triple layer mask also on top of that, because in case the child sneezes or generates aerosols, it's not a big risk. High flow nasal cannula was not available for a long time for us, but then now it's available. But in high flow nasal cannula also, there is a likelihood of generation of aerosols, so you have to be careful. So it's better that you always use this, if it is possible, to use it in a negative pressure room. Even if you are using it, you can again put one mask, triple layer mask over the nose and covering the nose and mouth, so that aerosol is not spread is reduced. And routinely, NIV uses, that's non-invasive ventilation use is not recommended. Again, there is a there's a chance of generation of aerosols during this procedure also. But then if you don't have any other option, you can use that. Indigenous CPAP, we use that routinely in our ICUs. You can use short trial. Again, indigenous CPAP also on the nose and mouth, it's better that you keep one triple layer mask. And if you can use oxygen hood also in small babies, again, that also will reduce the risk of aerosols and droplets in case CPR is needed. But then very important that it's an emergency, we all know. CPR is an emergency, but then protection of ourselves is also important. But if we are not there, other children cannot be saved. So it's important that we are protected. So it's very important that you be in full PPE when you do CPR in a child with suspected COVID. And it is always better that, so child is in cardiac arrest, you know that you need to act immediately, but then you have to make sure that you are safe. Your safety is also actually a number one priority here. So transfer the child to an isolated area if possible, wear full personal protective equipment. And this is one thing that they have suggested, that is a use of an ambu bag with a filter attached between the mask and the bag. You know, we have HME filters available in our ICUs, heat and moisture exchange filters that can be used. You can see that I don't know whether that's very clear in the picture there. An HME filter that is placed between the mask and the ambu bag. So that will actually generate, that will give some protection. In case CPR is needed, this is what you have to do. And when you decide to transport the child, very important that you inform the person who is sitting in the COVID ICU or phone that we are going to transport a child with a suspected COVID pneumonia, and the ventilator to be kept ready in standby mode, because we cannot afford to waste time there. Like the child is taken there on a nasal cannula, and then the child is very sick, and then again the chance of aerosol generation is more. And this is also very important that adding a viral filter at the expiratory limb, because again that's a very big source of infection. The expired air, the aerosols will be there for a very long time in the atmosphere. Full PPE during transport. And this I have already mentioned, that avoid all aerosol generation during transport, if possible. Again, I am re-emphasizing the importance of this PPE again and again. And in case the child has hypoxemia that is not responding to your conventional oxygen therapy, it's better that you do early intubation, because most of them require early intubation. And indications for intubation are there. I think it may not be very important at this stage for you here. Worsening respiratory distress, if the oxygenation is not maintained, the PaO to FiO2 ratio, PF ratio, and SF ratio is saturation of FiO2 ratio. Those are the values there. And if the child has multi-organ dysfunction also, that sometimes is in shock, child is not responding, there is an indication for that. And during intubation also, it is very important that the minimum required healthcare personnel are there in the room, because you need to avoid the risk. And it's always, these are the people who need to be there, like the person who is actually intubating, the airway operator, one person to assist, and a nurse for medication. And it's better that the most experienced person who can handle a difficult airway is there, because you cannot afford to have repeated attempts at intubation, because again that will actually generate the risk to the person who is doing this. And if possible, if available, video laryngoscopy can be used. We have it now, fortunately, in our ICU and the COVID ICU also. And you might have seen people devising devices like a transparent plastic sheet. There's an aerosol box and all that, which can be kept as a cover while doing this intubation, which can again reduce the spread again. And always use this RSI, that is a rapid sequence intubation, you know that, pre-medication, and neuromuscular blocker should be a short-acting one, like succinylcholine if possible. And ambu bag with filter, I have already discussed. The filter is very important. Like, and once you intubate, what we generally do is we just bag and then auscultate and see if the tube is in position. We know the 5-point auscultation to verify that the tube is in position. But then it is better that you avoid this. Because again, there is a risk of, if you do that, there is a risk of aerosol generation and possible increased spread. So if bagging, if possible, should be avoided. And if you can really have an expired carbon dioxide detector, it is always, that will tell you that the tube is in place now. Rapid sequence intubation is very important. It should not be done as an emergency, like as far as possible, rapid sequence intubation. And cuffed ET tubes are available even for very small sizes now. Even for newborns, it can be used. So cuffed ET tube, we have it now available in our hospital. If available, use cuffed ET tube always. And very important that this you inflate this immediately following intubation, because that will further reduce the spread. And this I already mentioned. If you can use the end-tidal carbon dioxide monitoring for verifying the tube position. And also you just look for chest rise. If it is there, again, you know that the tube is in position, rather than auscultating and looking for the position of the tube. And you can always take an X-ray chest afterwards to confirm the tube position. And this also you might have seen people using it. Nowadays it's available widely, closed suction. That is inline suction. Inline suction is there, means there are many advantages. One thing is that you don't have to actually extubate the child. I mean you don't have to actually disconnect the child from the ventilator to do this suction. You use an inline suction. Another thing is, another clear advantage is that if you use this, during ventilation for ARDS, they require some amount of PEEP. That will be lost once you disconnect the child from the ventilator. So that risk is less if you use this inline suctioning. So closed suction can be used. It's important that all our nurses and also physicians are trained in closed inline suction. Always, it's better that you avoid nebulization, again, to reduce the risk of aerosol generation. And you are placing the nasogastric tube only after intubation, because again, that increases the risk for aerosol generation. And only after intubation and ventilation is established, you put this nasogastric tube. And if anytime you have to disconnect the child from the ventilator, it's always a good idea to clamp the endotracheal tube, because if you just disconnect it and then the tube is kept open, like, again, there is a very high risk of aerosol generation and spread of infection. So clamp the tube. Actually, if you really want to disconnect the child from the ventilator, you clamp the ET tube, and then only clamps are available. Clamp the ET tube and then only do your procedure. Example, if you are actually changing the child from a transport ventilator to a ventilator that is there in the COVID ICU, means you clamp it in between. And instead of humidifier, it's always better that a heat and moisture exchange filter is used. We discussed about that when we discussed about bagging. And HME filter, better than humidifier. Nowadays, HME filters with low resistance for neonates, that small young infants are also available, so we can use that. And a viral filter in the expiratory limb, that's also very important. And always clean the room after 20 minutes after intubation, after 20 minutes, because that's the time it takes for aerosols to settle down on the floor or on the surfaces. So you clean it after 20 minutes. It's always ideal that you use a negative pressure room for all these procedures. And for ARDS management, prone ventilation has been found to be useful in improving oxygenation. Even in adults, mainly, they have done that. Extensive experiences there. In children also, people have started using prone ventilation extensively, especially in COVID pneumonia. It has been found that prone ventilation can improve oxygenation. So prone position is important. And important that you keep the child sedated, again, because a lot of complications can be avoided, like disconnection, aerosol generation, or can be prevented if the child is sedated. Very important that you keep a strict input-output chart. And positive fluid balance is found to be harmful always. So better that you keep the fluid balance negative or normal, positive fluid balance avoid, and management of, obviously, supportive management is there, management of shock and acute kidney injury. And Post-intubation, generally, we sometimes put the child on non-invasive ventilation afterwards, but it's better that you avoid that. You directly extubate and then put the child on conventional oxygen therapy. NIV is not. So you extubate only at that stage. That will be better. And some people actually cover the area with a plastic bag or sheet or something during extubation, again to avoid aerosols. So aerosol generation is the highest risk that can have for the healthcare worker here. And for specific therapy, there is no definite therapy that is evidence-based now. So people are giving many drugs, but then we don't know how effective it is because this is an evolving kind of disease. Like we don't know what's the actual evidence there. So it will take some more time, I think, for evidence to come. So remdesivir is there, new drug. I mean, people they have given emergency approval for that drug in the US now. Lopinavir, ritonavir, we have been using that for some time now, but then there is no strong evidence. So whatever evidence is there has come from our previous experience from the SARS virus, that severe acute respiratory syndrome virus or Middle East respiratory syndrome virus infections, and then experience with COVID-19 is yet to come now. We will have that maybe in another 5 or 6 months now. And hydroxychloroquine, all of you know, people are using that for prophylaxis also. But then again, the efficacy, there's no evidence as of now. People have started using that. Government guidelines are there for using it. And there are mechanisms also, right? It's effective. Viral load reduction is there with hydroxychloroquine. And also azithromycin also, we use that in positive children, RT-PCR positive children with symptoms. And azithromycin also we use that. There are other treatment options also because one of the complications that can happen is the cytokine storm. Cytokine storm can have disastrous consequences. So if that is there, people give drugs like tocilizumab also. That's an IL-6 inhibitor. And other drugs like interferons, IVIG. And nowadays people have started using convalescent plasma also. These are all the evolving stage. So we don't know. We don't have actual randomized controlled studies to tell you clearly that these are effective, but then it's not at time. So the data and evidence on COVID-19 is rapidly evolving. So what we do here, current experience is we start them on broad spectrum antibiotics. We give treatment for possible influenza with associated, because co-infection with other viruses and bacteria also are there, very commonly reported from China, especially. They have shown that co-infection with influenza and other viruses, adenovirus and other viruses are also there. Bacterial infections also like mycoplasma. So we routinely treat them with oseltamivir to begin with, azithromycin, hydroxychloroquine, antiviral drugs also. Thank you very much.
Okay, thank you, Dr. Jayakrishnan, for that excellent presentation. I have also joined. I heard only the last 2 slides of your presentation.
Thank you, Ashraf.
Anybody from Nursing College? Asina?
Sir,
okay.
there is a question. That was what type of clamp for clamping ET tube? There is a question asked by.
Any clamp can be used. Any type of clamp can be used. You have to make sure that it is closed. That's it. That's all. It will not damage the tube.
So, sir, thank you, sir, for your valuable and informative session. Thank you, Jayakrishnan, sir.
Thank you.
Thank you, sir. Our next session is on psychological impact of COVID-19 on child care. That topic is dealing by Dr. Anish, an eminent faculty from IMHANS Medical College, Kozhikode. In this time, we all know the cases of crime, child abuse, sexual abuse, depression, stress, suicide, all are increasing. And during the last 3 months, an official statistics is there, that is 66 students have got suicide. And in that 77%, of them, the causes are family problems and mental stress. 20 years ago, the health department has conducted a study on the adolescent and children suicides. In that, the most of the causes found was love affairs, but now it is changed. And for 6 students, the reasons are not known. And unofficially, under statistics is there, that is 126 students got suicide nowadays. And these are due to shaming experience also is one factor for their suicide. In this scenario, our government has started a Disha on call for alleviating the mental problems and all the suicidal matters. That is, and last year, that is from the 2019 April to this year, March, 12,000 calls from the various parts of our state have attended by this Disha, that is 38 professionals. They are working in Thaikad, Trivandrum, and they are handing over the mental problem cases to the DMHP also. And our police department also introduced a Chiri program with the help of student police cadets to alleviate the dilemma of academic matters, that is when the school reopens and the changing of to the online classes like that. And our government also introduced a committee, organized a committee in which the president is DGP R. Srilekha and the convener is TV Anupama, who is the director of Women and Child Development Department. That is exclusively for preventing the suicidal attempts by our children and adolescents. And these are all, and also another program that is by our social welfare department, that is Ottakkalla Oppamundu. These all takes at the relevancy of our topic, that is psychological impact of COVID-19 on our beloved children. Over to you, sir. Dr. Anish, sir.
Hello. Can everyone hear me?
Yes, sir. You are audible, sir.
Yeah. Good morning, everyone. So, as Mrs. Hasina said, I will be presenting on psychological impact of COVID-19 pandemic in children. As we are all going through this COVID-19 pandemic in the last 4 to 5 months, it has been a very intense experience, and it is an even more intense experience for our children. That currently everyone is being confined at home, and what we don't realize is that this is going to have long-lasting implications for the mental well-being of us and our children. So I will get into the presentation. So I will share my slides first. Can everyone see my slides?
No, sir. Can you put it in?
Yeah.
Share?
Now?
No, sir. Yeah. Now it's getting.
Okay.
Yeah. Now it's visible, sir.
Okay.
You may put it in slideshow mode.
Okay. Okay, thank you. We will do a very brief discussion about what are the psychological impacts of COVID-19 pandemic from the perspective of children, and some general preventive measures for how to address this the impending problems. So I will be talking more about the various issues that could lead to problems, and a general preventive measures. So in our current situation, this picture shows a few families, but as we all know, all these children are all isolated in their own individual houses. So that is the biggest problem here. So how all are children being affected? Probably the most important thing is that the schools are closed. That is the most visible thing for us. What is most obvious for us? And also out of home leisure activities has been curtailed. For example, they are not able to go out and play. They are not able to, go outside for some recreational activities, go for a movie, to a zoo, or things like that has been drastically curtailed. And also now the parents are supposed to do homeschooling, but at the same time, all these parents are mostly working from home, or they are going out. There is not enough support for childcare while they are away. I know people uh, for whom elder brothers who themselves are having online classes are taking care of younger children while they are attending the classes because the parents are working outside. And even if they are working at home, there are a lot of things that needs to be managed from house. And also the external supports for children. What we don't realize is that the caring for the children is not done only by not done by only by the parents, but also other members are involved in that. For example, grandparents, cousins, uncles, and all this in their vast network of support has fallen away because the social distancing measures have prevented people from coming together. And also there is less opportunity to be with friends. An important part of their growth is being able to interact with others of the same age. That is how they develop social skills. So this is another important thing that has happened. They don't have any interaction with people of their age, which mostly happens in the playground or in school. Also, there is a loss of structure. When there is school, you have to get up in the morning, you have to go to school, then you come back, you have, a certain structure when to have food, when to play, when to do your homework, when to sleep. Now that, everything can happen at home, it doesn't matter when you get up or when you take a bath, when you have a breakfast. And even if online classes are there, they are very less and they are very flexible in terms of, whether you should brush before you go to your online class or whether you should have your breakfast before you attend your classes. So that is also an important problem. And also, whatever happens to the parents will have long lasting impact on the children. So now the parents are stressed because of the various kind of worries related to COVID-19. The economic situation is worsening. Many of them have lost their jobs. Many of them are under threat of losing their jobs. Unemployment is rising. Many of them are not finding means to, take care of their daily bread. So all these worries will spill over to children because they are listening to us. When parents are having these conversations at home, children are listening to all of this, and naturally this will lead to stress in the children as well. Also, as mentioned earlier, this is a major issue, the risk of child abuse increasing, because there has been some studies in some countries which shows that child abuse reports have drastically come down in the last few months compared to previous months. This does not mean that child abuse has actually come down, because most of the child abuse, sexual abuse, physical abuse, psychological abuse, any kind of abuse, most of the cases are reported at home and in the neighborhood from the relatives. So now, even if you are confined at home or to your neighborhood, you can't expect your the child abuse incidents to be less. So which shows that there is less reporting of these incidents, while the risk and exposure to these incidents are higher than before, because there was a protective environment of school, there were other people involved, there was more supervision in terms of other agencies as well. Also, recent reports show that domestic violence has increased. That's happening at home. So children are becoming more of a witness to these incidents because parents are irritable, they are stressed. So there are a lot of violent episodes at home, and this all has a long-lasting impression in the minds of these children. And at the same time, activities of the child protection services and other support services have been curtailed because they can't go and first of all the reports are much less. They can't go and take cases or do inquiries or do investigations. or when the mobility is less, both reporting and actions from the agencies will be much lesser than before. Also, so now we'll come to the impact of school closure, because that is probably driving a lot of other changes that is happening in the lives of these children. Studies shows that 1.6 billion in 190 countries are affected. That is around 90% of the school age children who are not able to go to school. So this is a big issue, and it is bigger than we think. Many experts, experts from sociologists from Belgium said that this is a social crisis in the making. How? It can affect children in many different ways. One thing is the academic impact itself. For example, we don't, to be honest, we don't have lot many studies, lot many scientific studies, because this situation is evolving. So we don't know the real breadth and magnitude of the impact of COVID-19 in terms of school closure. But some studies which have been done in the past, especially when there was school closures for brief periods during snow and all, some studies have been there, which shows that there is more than 0.5% fall in the expected grades for each day loss in school. And also, if there is a 5-day loss, there is a 3% drop in the overall pass rate. Not only just loss in the academic performance, but also the pass rate is affected. So if there is a 30 children classroom, because of a 5-day school loss, there you can expect one child to fail. So now we should be thinking about a school closure for about more than 3 or 4 months now, and this is not going to be solved anytime soon. In many classes, especially in the lower classes, it is very questionable whether there will be any academic activity in school in this academic year. So if this is the effect of 5-day loss in school, we can't imagine what this is going to do in terms of academic performance. Some can argue that online classes can compensate to a degree for this, but we again don't know how much the online classes will be able to compensate these problems, because the studies is not something that happens just through the online medium. It is also the children, teachers' observation of the weak kids, and spending more time with them, and what the kids learn from the collective environment of a school, etc. Especially for lower classes like in kindergarten, in primary school, this is going to be a big problem. And now this news. We are all seen what happened. So this all leads. This points to another important problem: the social inequalities driving the problems that is going to happen with school closure. In this particular case, it is said that she was not able to access the classes because of the lack of computer or smartphone to access the classes. But overall, experts are saying that this school closure, this COVID-19 pandemic is going to exaggerate the socioeconomic differences between children, because whatever deficits that are going to happen, whatever problems that are going to happen because of the school closure is going to affect the disadvantaged population more, because they won't have the resources to for online classes. They won't have the resources to make up for the lack of the direct attention by the teachers. Some studies show that children from study was from UK, which showed that children from richer families could spend 30% more time on home learning than poorer families, which is understandable, because if the parents are richer, they don't have the pressure to work for long hours despite the lockdown. They will have more free time and they can spend more time with the children and taking care of their home learning. There can be other support systems, people who can take care of them. They can pay someone to take care of the children while they are working. So this is going to be a big problem, of a magnitude that we can't imagine. It is going to worsen all the socioeconomic differences. And also, especially in countries like India or the third world countries, school was also a place for nutritional support. And so many families dependent on the food available from school when these children goes to school. So now, so that the schools are closed, For many of them, that food is not available for them. So it is again going to worsen the food insecurity as well. And especially in states like Kerala, counseling services played a big part in identifying children who are falling backward, who had emotional problems. We at IMHANS have a lot of experience of counselors referring children with psychological problems, stresses, family issues, abuse, or even academic problems. So, it was easier to identify these children if they are in the environment of school and there was a referral system, some expert to identify the problems and refer early so that early interventions could be done. At a home environment where the parents are not aware or are not educated enough about the problems, again that can be a problem for many children for accessing services which can rectify these problems. So now coming to what all kind of symptoms can you expect when there are distress in children? What kind of symptoms that should we look for in these children at home, which could suggest that they are, they are not coping well? So there is, as we said, there is an enormous disruption which can present as distress in various forms. One thing could be worry or anxiety or fear. Even if children have anxiety disorders or depression, often it presents in age-appropriate worries or fears. For example, a child is not going to say that my life is useless or there is no point living on. A child may express in more age-appropriate terms whether my parents may leave me or my parents may die. I may get separated from my parents. My parents don't love me. So this would be more age-appropriate ways of expressing their distress. So sometimes they may express a distress as similar to those of adults, like fear of dying, fear of their relatives dying, or fears about treatment, different modalities of treatment. They may be more scared about injections or all these ventilator things that they are seeing. So often they present with irritability and increased demanding. Right now in our OPs in IMHANS, we see this as a big problem. The behavioral problems have increased among children. Children has become more irritable. There are more demands to go out, to play, to travel, or even sibling rivalry has increased because these children are interacting more with their siblings at home. So there are more chances of problems arising. There will be more demands for online things, phones or accessing online entertainment. So all this can lead to problems. So again, the parents are already stressed out, so there will be more pressure on them. So they may also react very negatively and in a very angry manner, which can even again worsen things. Also, we may see problems with eating, drinking, and also sleep disturbances. Some children may express their anxiety, may manifest their anxiety as nightmares, more nightmares, waking up more in the night, or some may be more withdrawn, or as I said, more aggressive. Some may present with physical complaints. It has been seen that often children in distress may present with physical complaints like abdominal pain, headache. This has been a case even before. Often children with depression or anxiety disorders may present to a general OP or a pediatrician with physical complaints rather than actually reporting any anxiety or depression. Also, clinging behaviors may be more. They may want their parents to be around them all the time. They won't let the parents out of their sight. So they may make these unrealistic demands about that parents should be around them. And also new fears may manifest. It may not be directly related to COVID-19. It could be related to something else, something magical or supernatural. But those kind of new fears, so often we see children who don't want to sit alone in their room anymore, who won't go to the toilet alone anymore, or who won't step out of the house anymore. So this kind of complaints may also be there, and play may get decreased. Often children may present with frank sadness, and sometimes it can lead to a clinical diagnosis of depression as well. We have been seeing in our OPDs right now of children who have relapsed, who have decompensated, who already had various behavioral problems, depressive symptom disorders or anxiety disorders, who were doing well on medications or on counseling, and currently they have decompensated because of the current situation. And also we have been seeing new cases. We recently even saw one or two cases of psychosis, acute psychosis, presenting with severe fears, hallucinations, disorganized behaviors. So all kind of psychiatric disorders can get precipitated in this kind of a situation. They may have a pre-existing vulnerability, but they may that can get precipitated in this kind of periods of distress. Now again, coming to something that was mentioned earlier here, cyber crimes. This also has been a concern even for the international agencies, because now in the current situation with all the online learning, the computers has to be provided to the children, and often parents are not around to supervise them, because if the child is having 2 or 3 periods of class, online class, their phones or computers have to be provided to the children, and a parent cannot be supposed to be around all this time, because he will be having other work, he may have online work, or he may have to step out of the house. So they are much less supervised right now. And so children after their classes often may be using Facebook or in other social media, or they may be using other videos, other sites, gaming sites. There has been a few reports, I don't know whether you people read about this. There was 1 or 2 reports even in India about children spending lakhs of rupees of their parents on gaming, for buying amenities inside the gaming systems, which the parents didn't know. A child spent around 10 to 15 lakhs of his parents' bank account, and the parents didn't know. How did the parents don't know? Because even the notifications from the banks that come are also in the same phone, and the parent had to give the phone to them for all these purposes. So this happens because there is a limit to the number of computers or phones that can be in a house. If there are 2 children or 3 children, they all need computers or phones at the same time when there are classes happening, and so often parents are forced to give their own phones or computers, and parents are not around to supervise things. So it is said that there is more risks of online exploitation, online manipulation, and things like that happening right now. Yesterday I read a news item about a child committing suicide in India, I think in Mumbai. I don't know how many of you read that, because that after the online classes, the child was playing games and the parent was not aware of this. And when another sibling started his online classes, the mother had to take this phone from him, and he went and committed suicide. So probably this all shows that there is a bigger dependence of children on online devices, even when the classes are not happening. One way parents take care of their children to avoid problems at home, they quarreling, children getting into trouble, destroying things. One easy way for parents is to give screen devices, and probably this is something parents are also not thinking about wisely, carefully. There has to be a limit on the on-screen devices. Even if you are giving phones or computers for classes, you have to be monitoring them. You have to check the browsing history after they give back their computers or phones. You have to check what the child has been using. There are different settings in current smartphones, many child lock settings. You can use the child lock settings in YouTube. You can use them in app stores. You can use in the whole computer as well. For example, in tablets or phones, many of them have this child lock settings which won't open age inappropriate sites or applications. So these are some things we all need to be careful about. Now, this is another group who is going to suffer the brunt of this whole COVID-19 lockdown. We are seeing that very often in the last few months in our enhanced OPD. Children with special needs like intellectual disability, various kind of behavioral problems, various kind of developmental problems, speech problems. So now for them, the problem is that interventions has to be quick and early. You know, a child coming to you with autistic spectrum symptoms at 3 years have a much better prognosis after interventions than a child who comes to you at 6 years. But the prognosis is only better if you can provide intensive interventions. For example, Enhance had an autism clinic where all this multidisciplinary team was there to give this intensive interventions. A lot of the interventions was based on group interventions, parental training, group therapy, group physiotherapy. So now all these things have been stopped. We are not in a position to provide any of these interventions. Many of the interventions we are trying to do it online. We have been trying to provide special education services, speech therapy, other psychoeducational services through online. But all the patients may not be in a position to access these services or use them appropriately. Often the parents have to be taught how to provide speech therapy at home or how to provide physiotherapy at home. And all this is not practically possible right now. So we, even now when we see children who come to our OP with developmental problems, there is a big issue how to follow. In between the lockdown, they can't come to the OP. Their movement is restricted. At the same time, if we were able to provide intensive sessions for them weekly right now, it would make a lot of difference in their future. But often they find it difficult to come. So these are all things whose impact we are only going to realize after a year or two. Many of these children who could have improved a lot will suffer because of the lockdown. So, and also many of these children with special needs have a risk of a serious infection because they also have other physical problems, you know, lung incapacity or other mobility issues, who all may have more complications. Many of them may have cardiac issues. So they may also have a serious complications of the infections as well. And their mobility is affected inside house. This leads to higher frequency of behavioral issues as well. So this is another group which I have to, you know, I will just mention in passing. Children in quarantine. Often it appears that, you know, a parent is infected, a contact is a child, and they may have to be put on quarantine, or a child is in contact with one infected person, but the parents are not in contact. Situations like that have arisen. So they may have been detached from their parents, leading to everlasting, you know, psychiatric consequences. Studies from earlier, which had showed study children who were quarantined for other reasons, have shown a higher incidence of post-traumatic stress disorder, anxiety, psychosis, you know, suicidal behaviors, etc. So this is another group which need to be studied in more detail specifically. Now another issue is that, you know, all this has a cascade effect. You know, overall the mental health morbidities are rising, not only in children, even in adults. And all the adults are often carers, parents, providing support to children. So when unemployment is happening, we are going to see record levels of unemployment in this coming years. You know, the real impact of unemployment we are only going to see in the next 6 months or next 1 year. So all these high levels of unemployment, income decline, debts that is not being able to be repaid. There are a lot of loans for many people. So all these are going to affect the parents. So their mental well-being is affected, leading to higher rates of mental disorders. Substance use is also going to increase. Suicidal behaviors are going to increase. So all these are going to have an impact on the children as well. And it is also seen that, you know, if whenever there is a low socioeconomic status, it directly, studies have shown this, there's a direct correlation between a lower socioeconomic status with the mental health of children. which is understandable because due to many other different ways, the support systems will be less, parental morbidity will be higher. So all this can lead to child mental health issues in many different ways, converging from many different pathways. So if we want to talk about the mental health of children, we also need to talk about the mental health of adults. So now coming to the last part of my presentation, how do we prevent or try to prevent these problems? How do we at least try to reduce the magnitude of these issues? So one important thing is giving quality time. So what is quality time? Giving quality time doesn't not only mean that you are sitting with your child. You are ensuring that you are involved in a meaningful activity with the child, something the child is also partnering in, and you are also partnering in, and you are ensuring that child is actively participating. So it doesn't just mean that you are sitting in a corner looking into your phone, into WhatsApp, and the child is playing on the other side, or the child is looking into the TV. So that is not quality time. Quality time means you are involving with the child, you are studying with him, you are playing with him, you are telling stories to him, your time is totally dedicated to the child. So this is a big indicator. This is a big correlator with child mental health, and especially in these times where stimulation from other means are not there. Parents have to make sure that they spend quality time with their child. You may be with your child, you may be with your child 24 hours a day, but it doesn't mean you are spending quality time. And there will be a lot of concerns for the children about their future, about COVID-19, and the things happening, the financial situation. So to a certain extent, you have to be honest with children. You can't hide everything. You have to explain things based on their level of intelligence. And children are perceptive. They will model their behavior from their carers. So if you are very anxious, for the parents are very anxious, and parents are quarreling, parents are acting out, these are all going to be behaviors modeled by the children as well. So when we psychoeducate the parents, we need to be aware of these aspects as well. And parents also need to seek support for managing their own stresses. So that is also important. So whenever you see children in trouble, you have to make sure the parents are also receiving adequate care. Because if the parents can't cope their stresses, they are going to take it out on the children. And that always is a big issue. And another important thing is there has to be a structure. There has to be a specific time when children wake up, when they do their routine activities, when they study, when they attend their classes, when they play, when they watch TV. There has to be a timetable for all these things. And it has to be made sure that there is time for creative activities as well. It should not be just about watching TV from morning to evening. So there are some guidelines that I have taken from an enhanced leaflet. So provide assurance whenever needed, listen to their concerns, and spend time with them, and also manage your child's anxiety. Often the child is anxious, but you don't know what to do about it. Talk to them and watch for cues of anxiety, whether they are becoming more irritable, more clinging, expressing more worries, becoming more withdrawn. You have to look out for these symptoms, and then you have to reassure them and explain things to them. Engage them in indoor activities. This was what I was talking about in terms of quality time. You have to spend more time with them and make learning fun. So it means that you have to dedicate time. That's that's what's there here in nutshell. Involve them in exercises, yoga, dancing, household activities. Everything need not be about some fancy play or games. You can make them learn some household activities, participate them in household activities, give them responsibilities, make them help in the kitchen, and also keep them in contact with their friends. They can't play with their friends, but they can still talk to them. You can organize online activities with them, online games with them, online conversations with them, and give them clear information. This is what I said earlier. You should not hide facts. You should be able to explain things to their intelligence level. And all, as I said, there has to be a structured routine of learning at home. So these are the various things that we can keep in mind. And of course, there has to be referrals made. If, as healthcare providers, you may all be in contact with children. And if there are issues that you feel are there in the children or in their parents, cases needs to be referred to mental health professionals. And it is not something that has to be dealt in the end, because often compliance to treatment, compliance to quarantine measures, compliance to medical measures will depend on their mental health as well. So those consultations has to happen in parallel. So I would conclude here. Thank you for patiently listening to this presentation. Okay. Any questions?
Sir, no questions from the
There's
participants.
a question in the chat box, Hasina. Any program is now on by IMHANS regarding this? Any online program? That was the question.
Yeah, I will briefly describe the programs we have. One thing is we are also part of the eSanjeevani OPD. So that is our clinical service right now. We have right now child OPDs are still functioning on every day. We have child services every day functioning as usual. In addition to that, we have online consultations on Tuesday for children from 10 to 12. So anyone who has problems, or anyone who wants to refer someone, they can go to the eSanjeevani OPD, which is a government system, and they can register and do a consultation from 10 to 12. Usually, many of the things may not be able to be taken care of in an online setting, but we can at least plan what to do in those online consultations. Now, we have a number of other programs working. Everything is not directly related to children. We are doing regular consultations in destitute homes here. So we have programs related to that, because there was a recent scare of some COVID positive cases in the destitute homes as well. So we are trying to deal with the psychosocial issues related to many of them being shifted to the destitute homes. Also, we have online regular, we have a YouTube, we have started a YouTube channel called IMHANS Resources, through which we are trying to provide all these, various parts of the, child services, like, speech therapy, physiotherapy, and psychotherapy. All these things we are trying to provide online, and there are a number of psychoeducational videos about how to provide these therapies at home for parents at the YouTube channel IMHANS Resources. We have recently released a series called Therapist at Home. If you search it, you can find a series of videos. Also, there are a number of adult services happening related to domestic violence as well. Probably I am missing a number of them done by different departments. So, if you want more information about all the services, you can check our site. IMHANS website provides information about all these services.
Thank you, Anish, for that excellent presentation, because the psychosocial support is very important in the management of the COVID. We know several persons are dying in Gulf and outside India, and most of the death may be due to stress rather than the COVID. Even there is an entity called stress-induced myocarditis. Now the terminology become increasingly popular, because if they are isolated in a room, there is no social support for them. There is no one to chat or no one to discuss. that
Yes.
produce lot of stress that even leads to myocarditis. So in the COVID management, as far as the nursing care is concerned, the frequent just talking with the patient over the mobile is also very important.
Yes, because all these patients will not have their usual support systems. There will be people they talk to when they are stressed, or there will be family members. They don't have any of the support systems. So those things will have to be kept in mind as well.
Over to you, Hasina.
Thank you.
Thank you, Anish sir, for your valuable and informative presentation. You tested all the aspects of psychological impact that's on children, family, parents, and all the work doing by the IMHANS. And the next session is by Dr. Ashraf sir, President IAP Kozhikode. That's on an overview, a pediatrician's view about COVID-19 in children. It was actually planned as the first session, but because of his busy schedule, we have this is third session, and he is very active, and he makes the others also active, and he organizes a lot of things under the banner of IAP. And today also he was on such a program that is rendering TV and dish connections to needed children. It was a program by IAP to alleviate the sufferings faced by the community, primarily aimed on children. And over to you, sir.
Thank you, Hasina, for that nice words. And thank you, Pannamma Madam and the team Nursing College for inviting me for this session, and also allowing us to join Department of Pediatrics as well as the IAP Kozhikode to join with Nursing College for the materialization of this Zoom series. Anybody outside from Kerala in the group, Hasina? All are from Kerala, participants.
No.
Yes.
Some of our
Okay.
alumni are joined.
Only nursing college from Kerala. No outside college is there. All are Malayalis. Delhi is there. Okay. Okay. But I will give you, as Hasina rightly pointed out, actually it was the first talk, but I have to attend another program. So I requested her to make it third session. Even persons from Saudi has joined, Bindu Bharati from Saudi Arabia. Okay, thank you. Welcome, Bindu. Then we will go to our session. On the slide share active. Okay, it is active. Whether my screen is visible? Is it visible?
No, sir.
No. Okay, I will retry. Some problem. That's not visible.
No, sir.
Okay. I will close and reiterate. Some problem. Now it's okay.
It is coming, sir.
Yeah, I will go to the slideshow. Okay. So, whether it is visible now?
Not yet, sir. We are waiting.
but it is showing sir has started screen sharing.
It is already shared. What happened?
Yes, sir. Sir,
Yeah.
can you go to the PPT, sir? Now, sir's
Yeah.
screen is visible.
Whether the second slide has come?
Yes, sir. Can you please go to the slideshow, sir?
I already gone to the slideshow.
Yeah,
It takes few seconds to
Now
download.
perfect, sir. Now perfect.
Now it's okay. Thank you. About, I will give you only an overview of about the COVID in children. That is COVID tips in pediatrics. The first thing I want to say is, in this COVID situation, the first thing we should do is we should be realistic. When it is occurred 3 to 4 months back, or from January onwards, even the Kerala reported the first case. We are having lot of postulations that it will be over by March, it will be over by June, it will be over by July, but it is not over even now. So according to this is a statement by Mike Ryan. He's a WHO emergencies expert. He's already said 3 months back, this virus may become another endemic virus. Lot of viruses are like that. It will become an outbreak first, then it may cause epidemic or a pandemic. Later, it stay there. It become an endemic virus. Endemic virus means that will be there forever in our community or in our locality. That is endemicity. So this virus may become another endemic virus in our community, and this virus may never go away. I think it is important that we are realistic, and I don't think anyone can predict when this disease will disappear. I think there are no promises in this, and there are no dates also. So now we are all also become realistic. It will take time. So we have to learn to live with this virus. That is the need of our. We should learn how to live with this virus. This is may settled into a long problem, or it may not be. Sometimes it may go, but we should expect we have to live with this virus. That is the first message I want to convey. Then, why COVID, a separate discussion of COVID in pediatrics is important? Because of all these factors, it is important. One is, children will have only mild symptoms or totally asymptomatic. So most of the infection, COVID infection in children will be asymptomatic or mild symptom only. Then at another point is, there is a prolonged viral shedding in children. And compared to an adult, the viral shedding is more in children. Then these two factors make the children more vulnerable, potential source for community transmission rather than adults. So epidemiologically, it is very, very important, even though the children may have mild symptom or totally asymptomatic. They will shed virus for prolonged period. Then symptoms of COVID-19 are similar in children and adults, but the severe symptoms are very, very less in children. The initial symptoms, children include cold-like symptoms such as sore throat, fever, running nose, cough. Vomiting and diarrhea may be a more common presentation in children, according to several studies conducted in the Europe and China. Even though we are having a number of cases, less than 25 cases in 30 cases in Calicut, the diarrhea is not a common manifestation here. But studies are saying vomiting and diarrhea also may be a manifestation of the COVID infection, which is little bit more common in children when compared to adults. Then, this is a study published by Lancet. The conclusion is severe COVID-19 in children is very rare. To date, the largest review of children with COVID-19 included 2,143 children from China. Only 112, 5.6% of these children had severe disease by defined as hypoxia. That severe definition of the severe disease or category C is different from in this study. Any child with hypoxia is categorized as a pulse oximetry if the SpO2 is below 94. That considers as severe disease, not severe respiratory distress or severe hypoxia. Only if there is a hypoxia, according to this study, it is severe disease. Only 5.6%. And 13% children developed respiratory distress or multi-organ failure or acute respiratory distress syndrome. That means only 0.6%. A very severe disease is only 0.6%. According to their study, 5.6% is having severe disease, but the definition of the severe disease and hypoxia below 94. It is different from our category C. What is the category C? We will discuss later. Then at the time of rating, there have been 2 reported deaths in children testing positive for COVID-19 in China and no deaths in Italy. This study is published 2 months back. We are waiting for formal reports of outcome in children from other countries, but to date, no deaths have been reported in the published literature. That is also a brighter aspect in COVID in children. These figures are in stark contrast to the 4%. In several countries, it is 7.5%. Some of the countries, it's the 10%. Even now, India, the percentage of death is less. Kerala is very, very less. But the overall global mortality is 4%. But children, it is very negligible percentage. Although death rates from COVID in children is low, I already said the medical professionals and parents are concerned about the transmission because of the asymptomatic or mildly symptoms and prolonged shedding that pose a huge threat for the transmission in COVID children, COVID-affected children, from the COVID-affected children. And that is the importance of the topic. We all know the categories. The COVID is divided into the category A, category B, and category C. The category A means mild sore throat, cough, rhinitis, and diarrhea. Previously, during the January or February, we will always ask about the contact in the any history of contact. Now, slowly it becomes irrelevant because there are some cases or some outbreaks are there in the community. So, previously, any child with a mild sore throat, cough, rhinitis, with an epidemiological contact of a COVID positive patient or a COVID suspect, then we will call it as a category A. But the present situation, any patient with a mild sore throat, cough and rhinitis or diarrhea, we should consider him as a COVID suspect. Whether we have to send for the laboratory confirmation or not is a different issue. But the things are, we should take all other protection in dealing with this children. So in simple words, in any patient dealing businesses, any patient dealing affairs, we should take due precautions and appropriate personal protection equipments. Then category B means fever and or severe sore throat. So category A, there is no fever. Fever is there, it becomes naturally category B. Fever, severe sore throat, cough, diarrhea. Or a category A symptom, that means no fever, mild sore throat with any of the following. That means lung, heart, kidney, nervous system, cancer, HIV. Long-term steroids, immunosuppressive drugs. In pediatric patient, children in leukemia, chemotherapy, or a child on Visalon, prednisolone for nephrotic syndrome with a mild sore throat become a category B. It is not category A. But if any of these risk factors, category A symptom makes category B. Any child with this comorbidity with a category A symptom should be considered as a category B. Then category 3, it is not a pulse oximeter or hypoxia diagnosis here. In that study, it is a pulse oximeter or hypoxia diagnosis. Here, breathlessness, chest pain, drowsiness, fall in blood pressure, respiratory distress, and severe acute respiratory infection community acquired. In this COVID situation, any child with a severe respiratory infection, in simple words, any child with a respiratory infection requiring hospitalization should be tested for the COVID, because the community acquired pneumonia, the cause may be severe acute pneumonia, the cause may be COVID. Then, the most important thing in the patient management is triaging of the patient. So, the hospitals are the most important potential area with a high risk for the transmission. So, the ideal recommendation, the category A should stay home. In several countries, in all of the countries, and in other part of the India also, they are staying. But because of the constant vigil and importance from beginning, we are hospitalizing even the category A. Now they are going to the primary corona centers. First primary care centers are now established by the government. They are not admitting them in the hospital. But as the case number is increases, we also will compel to make them stay home. And it is not home isolation or house isolation. It is the room isolation in the house. Ideally, the terminology should be used this. You should stay in a room in your house, preferably in a bath attached room. And the medical assistance can be given by various modalities of the telemedicine, including WhatsApp and mobile phone, etc. Only one important threat in pediatric age group, it is safe. Isolating them in the home, in a room in the home is the ideal for the category A symptom. Hospitalizing such children will increase the chance of transmission to other children and to the community. Room isolation is the ideal. But in adults, one of the important threat of room isolation or house isolation with a category A symptom patient is there are several reports of sudden development of severe hypoxia even without severe respiratory distress. The explanation and studies will come later, but there are some case reports like that. Sudden hypoxia without much respiratory symptom and even deaths. That is the one risk of home isolation or a room isolation in a home. In hospital, every hospital, if we are dealing with COVID and non-COVID patient especially, there should be 3 levels of triage. Triage 1, triage 2, and triage 3. So, at least the respiratory OP should be different from non-respiratory OP. Recently the department pediatrics is functioning like that. We are seeing the respiratory cases in one room and all other non-respiratory cases in another room. And providing a triple layer mask to child as well as the bystander is important. Even though resources are not permitting us, that is the ideal. In the recommended personal protection equipment, there is no role for the 2-layer mask or cloth mask in the hospital setup. Whether it is the doctor, staff nurse, paramedical staff, or a patient bystander, the minimum protective equipment is 3-layer mask. So any child over the age of 2 years should be provided with a mask while examining. The bystander also should be provided. But in a resource scarce country like us, it may be sometimes difficult. Then at least a cloth mask should be wear by the parent or the bystander, and the bystanders. If you are seeing a bystander above the age of 60 or 50, please try to discourage them. Please send them back to home, because in adult, old age people, citizen, all the senior citizens, the mortality rate is very high. So bystander should be any person below the 50 ideally, or below the 60 at a maximum. So they have to provide it during the IP also. All of them should be provided with a 3-layer mask. Indirectly, that step will decrease the chance of infection to the healthcare workers. Then, usually, anything you discuss with the patient, not only the history taking, it is better to keep 1 meter distance. It may be difficult to while giving an injection, but all other conversation during the IP entry, during the OP register entry, all this should be done at a minimum distance of 1 meter. What happened in our wards? Just think, most of the time, the patient and 2 bystanders will come with a child. The staff nurse may be sitting in that nurse's station, and they are keeping very close with this. It is very simple to preach about the social distancing. But one thing we have to realize is that the social distancing is important inside the hospitals also. So it is. I will also always say, if there is a space, it is better to keep the 2 tables and sit. Then it makes 1 to 1.5 meter distance will be there. So everything should be at a distance of 1 meter minimum. Ideally, it is 2 meters. All the other conversation, especially in the isolation rooms, in the wards, may be made through the mobile phone. Then, in a pandemic like this, safety of us medical workers is also very important. We often forget that. So, only minimal interference in and examination. For the doctor, the minimal examination is required. It is not advisable to repeatedly looking for a small spleen. So in nursing care also, the minimum essential thing we have to do, and try to do it at a social distancing. Ideally 2 meters or at least 1 meter. Then this will come in a later talks. Testing strategy. Being COVID is an evolving situation, all these strategies are changing. Previously, the category A, we are not testing. Now we started to test the category A also. This is a slide prepared previously. So it is a live document. There is frequent changes in the guideline issued by the government. So even though the previous guideline, any child with severe acute respiratory infection should be tested for the COVID. That is there even in the first guideline onwards. Then, depending upon the situation, you have to arrange the investigation. It is better to do only needed investigation, only essential investigation in a case of COVID-19. Otherwise, lot of other supportive department also handed to this sample, the laboratory people. So only minimum. The guideline recommends so many investigations, but we are doing only minimum needed essential investigations. Then, regarding the treatment, in this COVID era, it is better not to take any other antibiotics except paracetamol if it is absolutely necessary in any patient, even ourselves, for the fever. We don't know the fever of my mother may be due to COVID or non-COVID. So it is better to avoid in general all other antibiotics except paracetamol. Paracetamol is safe in all these situations. Then one of the important thing is the commercial hospitals are increasing. Now there is a trend to prescribe MDAs, even the nebulizers for the using at the home. But all the nebulizations are aerosol generating procedures, which pose a high risk to the bystanders as well as the healthcare workers. So avoid nebulizations as far as possible. Instead, we can use metered dose inhaler with the mask. Metered dose inhaler with the space inhaler and mask, which is equally potent to a nebulization in a severe acute asthma. We can repeat it like that of a nebulization every 20 minutes, etc. Then antibiotics, we are usually in a child with a category C or B, we are prescribed the antibiotics. We have to avoid systemic steroids. Suppose there is a COVID patient in a contact with a COVID patient, a child with a nephrotic syndrome on steroid, that is on the nephrotic syndrome is in the remission. It is better to discontinue steroids, even though inhalation steroids usually prescribed in asthmatic children. In this COVID situation, if you are able to discontinue it, it is better to discontinue. Non-invasive ventilation also to be avoided if possible. And every suspected of case of COVID, initially we will give oseltamivir for the influenza-like illness, considering it an influenza-like illness. And when usually the oseltamivir will give at a dose of 3 milligram per kg for 5 days. So we will admit the child, we will start on oseltamivir and send for COVID test in a suspected case. If the COVID test become positive, we will discontinue oseltamivir. If the COVID test is negative, we will continue the oseltamivir. That is the practice. And HCQ-son chloroquine base and azithromycin. These are the usual medication used. Details about this will be given in subsequent talks by other speakers. There is a separate talk on the guideline of management guidelines. So the category B, category A, I already said we are not giving any antibiotic, any treatment. Category B, we will start on hydroxychloroquine plus azithromycin plus oseltamivir, isolation modula. Then if the COVID test is positive, we will discontinue oseltamivir. We will continue hydroxychloroquine, azithromycin. Hydroxychloroquine dose is 6.5 milligram BID on the first day and 3.25 milligram per kg into 4 days. Total 5 days. First day 6.5 milligram. Second day onwards, half of that, 3.25 milligram per kg BID per kg per dose. Twice, first day 3 milligram, 4 days. That is 5 days. Azithromycin dose is 10 milligram per kg first day and 5 milligram per kg next 5 days. Even though we will start oseltamivir on the time of admission, when COVID test become positive, we will discontinue azithromycin. Then category C, the treatment is similar. We will give hydroxychloroquine injection azithro or azithro plus lopinavir. Suppose the child is chloroquine is contraindicated in child, we will consider lopinavir or ritonavir. That is anti-HIV medication. But a single medical practitioner is not entitled to prescribe antiretroviral therapy for a COVID for category C COVID child, but it should be done in consultation with the state medical board. But these are the simple words, the management of the category. Then one of the important concern is about the HCQS prophylaxis. There are different recommendations. The person who discussed the guideline will discuss that. But one thing I want to convey is the HCQS prophylaxis is not recommended in children less than 15 years. അപ്പൊ 2 വയസ്സിന്റെ താഴെയുള്ള കുട്ടികൾക്ക് മാസ്ക് റെക്കമെൻഡഡ് അല്ല. 15 ഡേയ്സിന്റെ താഴെയുള്ള കുട്ടികൾക്ക് HUQS പ്രൊഫൈലാക്സിസും റെക്കമെൻഡഡ് അല്ല. പിന്നെ വേറെ പല കാര്യങ്ങളും പല ആളുകളും പറയുന്നുണ്ട്. വൈറ്റമിൻ ഡി, there is no scientific data support. വൈറ്റമിൻ ഡി കഴിച്ചാൽ കോവിഡ് വരില്ല എന്നൊക്കെ പറയുന്ന കുറെ വാട്സപ്പ് ഗ്രൂപ്പുകളിലെ ഡിസ്കഷൻസ് കാണാം. ബട്ട് in really speaking, there is no scientific support basis for that recommendation. No business of vitamin D. Then regarding the newborn, immunizations given as per recommended, and rooming in is also allowed. That means keeping the baby along with mother, but rather than keeping the same bed, it is better to keep the child at least 2 meters away from the mother's bed in another bed. But breastfeeding may be given with adequate protection. Mother have to wear N95 mask, etc. Then regarding the children, play is very important. So for our children also, it is better to discontinue the contact sports during this period. The children at a home can play themselves rather than going for a football or a volleyball, even a cricket. It should be discouraged. The contact sports should be discouraged. Then the most important aspect of the prevention, we have discussed about the triaging in simple words. Then personal protection, there is a spelling mistake there. PPE, it is not PEP, it is PPE, personal protection equipments. That should be covered in other classes. Social distancing, that is the most important thing, and the behavioral changes. These 2 things are very important in the prevention. So I already mentioned social distancing at workplace is important. The cafeteria area, in the canteen, in the nursing station, while dealing with the patient, while dealing with the doctors, while dealing with the paramedical staff, while dealing with the administrative staff. നമ്മൾ വിചാരിക്കരുത് നമുക്കിത് വരില്ല. Anybody in the world, in the universe, the chance is there. So consider all others as infected, even though they are not infected. That is the best policy. Keep all social distancing norms in all interactions. We often, health workers often forgets that. Like നമ്മൾ മുമ്പ് കണ്ടു, ഒരു പേഷ്യന്റിനൊക്കെ ഡിസ്ചാർജ് ചെയ്യുമ്പോൾ ആഘോഷത്തോടു കൂടി ഒരു മാസ്ക് ഇട്ട് എന്നുള്ള ഒരു കോൺഫിഡൻസിൽ ആഘോഷപൂർവ്വം യാത്ര അയക്കുന്ന ഒരു ടെൻഡൻസി ഒക്കെ ഉണ്ടായിരുന്നു. ഞാനതിനെ വിമർശിക്കുകയല്ല, നമ്മൾ ശ്രദ്ധിക്കേണ്ടതുണ്ടെന്ന് തോന്നുന്നു അങ്ങനത്തെ കാര്യങ്ങൾ. Then most important thing, hand wash. The mere hand wash will not protect according to the proper technique. Then suspected case നോക്കിക്കഴിഞ്ഞാൽ എന്തായാലും ideally, even after examining all the patient, which may not be practical in several occasions. So frequent hand washing and use of sanitizers after examining each patient. It is better to, for the nursing profession, it is better to give injections, especially in the respiratory cases, as a last session during the injection rounds, and sanitize after each injection in a gloved hand. That is the ideal practice. Nothing impossible to do if you are having a will to do that. നമ്മളൊക്കെ മനസ്സിൽ എപ്പോഴും ഉണ്ടാവും അതാണ്, ഇതൊക്കെ കൂടി നടക്കുമോ, നമ്മൾ വിചാരിച്ച നടക്കാത്ത കാര്യങ്ങളൊന്നുമില്ല. പക്ഷെ we will blame, we are too busy. പക്ഷെ this is a debate between the busy and life. So take utmost care in all dealings. Then one important thing is mannerism. All of us have our own manners. ചിലവരിങ്ങനെ മീശ പിരിക്കും, ചിലപ്പോൾ കണ്ണിങ്ങനെ ഇടയ്ക്കിടയ്ക്ക് ചൊറിയുന്നുണ്ടാകും, ഒരുപാട് മാനേഴ്സ് നമുക്കുണ്ട്. അപ്പം നമ്മുടെ we should think about our mannerism. Any of us mannerism is helpful for the spread of the infection, willfully try to avoid that. എനിക്കൊരു ഹാബിറ്റ് ഉണ്ട്, ഞാൻ ഇടയ്ക്കിടയ്ക്ക് മീശ വെച്ചുകൊണ്ട് നൗ ഐ ആം വിൽഫുള്ളി അതിങ്ങനെ ഒഴിവാക്കാൻ ശ്രമിച്ചുകൊണ്ടിരിക്കണം. നമ്മുടെ ഫ്രണ്ട്സിനോടും ഫാമിലി മെമ്പേഴ്സിനോടും ചോദിക്കുക. ചിലപ്പോൾ ചില ആൾക്കാർ വെറുതെ കണ്ണ് ചൊറിഞ്ഞുകൊണ്ടിരിക്കും, ചൊറിച്ചിലൊന്നും ഉണ്ടാവില്ല. അപ്പൊ അങ്ങനെയുള്ള മാനറിസംസ്. പിന്നെ പേഷ്യന്റ് റൗണ്ട്സിന്റെ ഇടയിൽ കട്ടിലിരിക്കുക, അല്ലെ, കുട്ടികളെ വെറുതെ എടുത്ത് കളിപ്പിക്കുക. നമുക്ക് ചപ്പി കുട്ടികളൊക്കെ കാണുമ്പോൾ കളിപ്പിക്കാൻ ഭയങ്കര രസമാണ്. അതൊക്കെ ഈ ഒരു പീരീഡിലല്ല. ഇൻ ഹോസ്പിറ്റൽ പ്രാക്ടീസ് നമ്മൾ നമ്മുടെ ഡ്യൂട്ടി അല്ല, അതല്ല നമ്മുടെ ഡ്യൂട്ടി ചെയ്യുക. കഴിയുന്നതും അനാവശ്യമായിട്ട് ബെഡിൽ ഇരിക്കുക, ബെഡിന്റെ റെയിൽസ് പിടിക്കുക. നമ്മുടെ കോണി ഇറങ്ങുമ്പോൾ തന്നെ നമുക്ക് സപ്പോർട്ട് ഇല്ലാതെ ഇറങ്ങാൻ പറ്റുന്ന ആൾക്കാരല്ലേ, നമ്മൾ എന്തിനാണ് പിടിക്കുന്നത്? അപ്പൊ അങ്ങനെ നമ്മൾ ഓരോരുത്തരും ഈ ഒരു പീരീഡിൽ അത് ചെക്ക് ചെയ്യണം തോന്നുന്നു. ഗ്രീറ്റിംഗ് ഓഫ് കോഴ്സ് ഇപ്പൊ ആരും ഷെയ്ക്ക് ഹാൻഡ് നൽകുന്നില്ല. ഏറ്റവും ദ ബെസ്റ്റ് ഗ്രീറ്റിംഗ് ഈസ് എ simple smile in the face, but because of the mask it is not possible now. So decide or find out your own type of greetings. വെറുതെ ഒന്ന് തല കുളിക്കാൻ മതി, കൈ കൊണ്ട് ഇങ്ങനെ കാണിച്ചാൽ മതി. So the COVID has changed a lot in the world, and sincerely speaking most of them are good changes, but the bad changes are very costly. It is the morbidity and deaths. അതൊന്ന് ഒഴിച്ചു നിർത്തിയാൽ, മോർബിഡിറ്റിയും മോർട്ടാലിറ്റിയും ഒഴിച്ചു നിർത്തിയാൽ, actually COVID created a lot of good things. I think with this slide I am concluding now. I think I will have another session also. Sorry, ഈ ഒരു സെഷൻ ലാസ്റ്റിലേക്ക് മാറ്റിയതിന് sorry, because it is unavoidable. So in the hospital practice, previously one of my respected teacher PM Kutty sir always said the most important thing in the hospital and infection control is soap, water and common sense. We often forget that. We are using several other costlier things, but the values, the big thing is soap, water and common sense. Thank you for this, for the patient hearing.
Thank you, sir, for your valuable and informative session. Thank you very much. And few questions are remaining that should be to the Dr. Anish sir. Anish sir, please.
But there is a question in the chat box. Can you explain little more on types of masks to be used, number of layers? In the subsequent session, it will be handled, even though there is no role for 2-layer mask in a hospital setting. And the cloth mask is advisable in the community only, not in the hospital. It has no business in the hospital. And regarding the N95, etc., we will cover it in the subsequent sessions. There is another how to control mobile, Anishanda.
I will
how to control mobile misuse.
So regarding mobile misuse, there is no perfect time-tested way to do it. It all will depend on the kind of situation. For example, some of the parents will be using mobile phones to distract the children from other kind of problems. Some of them will be using the phone for academic purposes or gaming purposes. So the intervention will be different from another case. So some general things that we can advise in a broad way. One is that there has to be a set time for the phone, and this has to be clearly articulated to the children. Often the problem happens is that giving the phone to the child will depend on the mood of the parent. For example, parent is very distressed, or parent is distracted by something else, and the child is creating some problem on the side, and you want to take care of that problem for some time, and then you give the phone. So there is no, when the child realizes that there is no usual rules or things, whenever the parent wants, he can give the phone, then he will ask any time. So one thing that needs to be clearly articulated to the child is that phone will be available on a particular time and only for a particular period of time. Usually, we say that phone should not be provided for children less than 2 years. Even for children with age higher than 2 years, it should be used only sparingly, maybe less than 1 hour per day. That is some guidelines give such a duration, but even that should be limited. So when you are giving the phone to the child, you have to articulate the rules regarding why you are giving the phone for and for what duration you are giving the phone, and this should be consistent throughout through every day. So that is the most important thing. Whatever rules you formulate, the parents has to be consistent with those rules. If you are giving the phone only every day at 6 o'clock, fine. Or if you are giving the phone only for online classes, that is fine. Okay, you are giving the phone for playing games, fine. You are giving it for 20 minutes. You should take back the phone after 20 minutes. No matter what kind of tantrums or problems the child creates, he destroys things, he beats his elders, or he throws things. So I thought, maybe I will give the phone for another half an hour. If you do that, he will do the same thing the next day as well, because that behavior is rewarding. Okay, I created all these problems, so I got the phone, so I can do this. This is what will get me the phone. So you have to be firm. You should not get angry and get into fights and arguments, but you have to be firm with your rules. Whatever problems happen in the initial 1 or 2 days, those problems will come down once the child realizes that this rule is very fixed and there is no going back from the side of the parent regarding this rule. So that is the most important thing. The rules has to be consistent, the rules has to be firm, and there has to be an explained logic for the rules you keep for on-screen use. It should not be based on your whims and fancies, and it should not be flexible based on your moods. Okay.
Hasina, I want to add a point on that. If you are asking which device is better for e-learning, because we are in a situation the students has to continue, forced to continue e-learning at least for up to October or even August 31st, August last week, hopefully. So we thought a lot of about it while we are designing a program to assist around 35 children. Indian Academy of Pediatrics yesterday and today gave 35 television sets to the children with a dish antenna connection, and the charges for 6 months already paid, up to 6 months paid. If a smartphone is given without much instructions and counseling, it may harm the child. The smartphone is economical. We can give more children if we opt for smartphone. It will cost only around 9,000 or 10,000. But we decided to give TV without a smartphone connectivity, with a dish connection to avoid misuse. So I think the TV is the better device. It will be kept in a public space at the home. The mobile can use from anywhere. Anish, what is your opinion about that decision?
I totally agree. If it is possible, it is definitely the best solution. Wherever the data is limited, when TV is there is no other data to use anything else. And the problem with current phones, smartphones, tablets is that there are a lot of other things that you can explore. So if you are limiting the options and the screen can be only used for one specific purpose, well and good. In case, I can add on what sir said. Of course, if TV is available, that is the best option. Now, suppose you have a tablet, there is nothing else you can fall back on. At least take out the data, or limit the data. Take out all the other applications. Make sure there is a parental lock on the applications that can be installed, in the Play Store and everything. And take off all the other things. Limit the browser settings. There are a lot of things that can be done in current digital devices that can limit the data usage. So basically, when you are using a TV set, why it works is that it can't be used for anything else. The problem with the phone is that once the data is there, there are a lot of, there's a big world out there. Child can explore a lot of other things. So you can limit it in many different ways. Yeah.
Wind up ചെയ്യാൻ തോന്നുന്നു സീന അല്ലേ?
Sir, two more questions is there for Dr. Anish. Any online dyslexia clinic is available? And what about support of mentally challenged child with COVID?
Regarding the online dyslexia clinic, we are providing online services. Our speech therapists in child development services are providing online services. Usually what they have been doing is providing those services for children in our follow-ups. So, you know, if there is a new case, they can always register in the eSanjeevani OPD, do a consultation. And if there is no other issues involved, there is no other evaluations or anything is required, maybe they can be linked up with the online speech therapy courses. You know, our speech therapists often provide digital material. There is also downloadable manuals, work at home manuals available from our website prepared by our speech therapists. You can utilize that as well. Now, as I said, if there is a new case, if there are no other issues involved, maybe we can directly link up with the speech therapist, but probably what we usually prefer is at least to do one consultation directly and then link up with the online services, at least in Enhance. Other services, actually, I'm not much aware. Any one of them are, many eSanjeevani portal, there are many doctors available. I don't know about any online service. Regarding the care of mentally retarded intellectual disability children, again, the challenges will be different for different children. For example, for someone with a mild intellectual disability, the issue will be more about similar, many things will be similar to other children, like, you know, engaging them in activities, ensuring some amount of learning is happening, trying to involve them in some kind of online activities, parental you know, efforts in education. But again, if for some children the issues will be behavioral issues. We have been seeing a lot of cases with behavioral problems in case of intellectual disability. So again, these are all related to many psychosocial situations. For example, often there will be situations where they are being locked up in the house because, you know, they can't be left out, they can't go out. So there is not enough opportunities for recreation, opportunities to have some fresh air. So again, will depend on the needs of the individual child. General measures again would be, in case of, you know, behavioral measures, try to talk down, try not to take a confrontational attitude, try to identify what kind of situations with these behavioral outbursts are happening and try to rectify those situations, trying to, you know, have some kind of physical activities, some energy expending activities planned. You know, there are a lot of general measures. So I think that will do.
Asina, even though I said the mortality in children is very, very less, unfortunately, we had a mortality. The first case diagnosed, first a child diagnosed with the COVID at Calicut Medical College was died on 4th day, because that was a child with a severe congenital heart disease and development delay. And the child died at the 4th day. Several learnings we had from that case. So the counseling of the parents, talking with the parents, and situation after the death of that child is very, very difficult to manage, because the mother and father, the samples were sent, but the results were not obtained. So after dying the child, the mother is isolated in a room, and the father is isolated in another room. So the psychological situation of the mother, that was a difficult scenario we have to manage. But fortunately, on the Ratri we got the result and we keep them to in a room. അത് കുട്ടി മരിച്ചാൽ രാവിലെ കുഞ്ഞ് മരിക്കുന്നു, അമ്മയെ പിടിച്ചൊരു റൂമിൽ ഒറ്റക്കാക്കുന്നതെന്ന് ആലോചിച്ച് നോക്കി. അപ്പം there are lot of social issues, lot of psychological problems. അനീഷ് എന്താ പറയണ്ട?
I totally agree. You know, this kind of practical situations, you know, people always talk about mortality rate and morbidity and in cases of infected cases. But when we go to all these individual stories of all these people in quarantine, all these family members who had someone deceased in their family due to COVID, the kind of problems they have to go through in the immediate aftermath. There will be even bigger issues, I'm not saying even bigger issues. There are also so many associated issues that probably haven't got enough attention. Hopefully, where can all evolve a system so that some kind of support and communication is possible with people in quarantine,
Very important.
people in isolation. Yes.
Okay, thank you. Thank you, Dr. Anish.
Thank you, sir.
നിർത്തുകയല്ലേ?
Thank you, sir. Thank you, all participants and all the panelists, Dr. Ashraf sir, Dr. Jayakrishnan sir, and Dr. Anish. And we will hope this pandemic will become an endemic by the ecological equilibrium and the evolution process of the nature. We hope that. Thank you once again.
Thank you.
The feedback form will be available only for 10 minutes. So please be quick to fill up the feedback form. Thank you.
Anish sir, can we leave from our side?
Yes, sir. Yes, sir, you can leave. Thank you all for the active participation. Thank you.